I'm Bruce Lambert from the Department of Communication Studies and the Center for Communication and Health at Northwestern University. And this is part 3 of my presentation on a patient-centered perspective on medication use, self-regulation versus adherence. In the first 2 parts, I tried to talk about a model of chronic illness based on the trajectory model and also on the meaning of medications in connection with identity and biography. And here I want to talk about what we might do differently if we took this perspective seriously. So I personally am convinced that the trajectory model offers us the best model that there is currently available of the experience of illness from the patient's point of view, at least the experience of chronic illness, which is the dominant form of illness in at least in the United States now. It's the chronic illness consumes most of the resources and most of the medication, most of the hospital days, and so on. So if we took the trajectory model seriously, and if we took the BBC chain seriously as a model of health, and if we took seriously this notion of the centrality of identity and performances, how would we do things differently? How might we do research differently, and how might we design interventions differently to help chronically ill people get along better, suffer less? And instead of this asking ourselves this question of, how can we make people follow instructions, we'd ask ourselves instead, how can we help people improvise in this way that allows them to tackle these complicated, unending problems that occur to them? So the challenge is to build and test interventions based on the trajectory model. We haven't done very much of that. There are some. So this is, I think, one of the best examples I know of what it might look like to redesign a system of care in light of the trajectory model. This is developed by my colleagues at the Cincinnati Children's Hospital Medical Center. It's called the Improved Care Now Network, and it's a digital, web-centric care system for people with inflammatory bowel disease and Crohn's disease and ulcerative colitis. It's really a tremendous achievement, and I encourage people to take a closer look at it. I'm not going to talk about it in detail other than to say it's a relatively radical reimagining of the relationship between patients, providers, and in this case, parents, because the patients are kids. And I think it's an example of what care systems might look like if we took the trajectory model really seriously, because it really pushed patients in the center in an empowered way, which is unlike what we see in traditional systems of care that are clinic-based or hospital-based, and they've had tremendous outcomes. So what are some possible directions for research? I have some main ideas. First is that effective self-regulation will be positively associated with the extent to which a regimen restores or maintains the integrity of the BBC chain. I said this before. I have the single sentence theory of adherence. If a regimen helps you maintain the integrity of the BBC chain, people will follow it. If it doesn't, they won't. So this is the same idea, just phrased differently. Whatever helps people maintain the integrity of the BBC chain, this connection between the body, biography, and conceptions of self, they will do. So in order to do research on this, we need measures of all these things, which we don't really have. We need some sort of measure of the integrity of the BBC chain. Now, how do we know when these links are breaking down between body, biography, and conceptions of self? There are measures of quality of life and functioning which approach this, but I don't think we have anything specifically which does it. What does the success of biographical work look like? I didn't talk too much in part 1 and 2 about biographical work, but biographical work is one of the 3 kinds of work that chronically ill people have to do. It's all the work we do to maintain our identity and our biography in light of the limitations and body failures that chronic illness imposes on us. So some people are successful at biographical work. I think we all know people who have serious chronic illnesses who nevertheless are happy and in some sense even healthy. In the BBC chain sense, they're healthy, and they lead full lives, rich lives, full of meaning, full of purpose, that their friends and family would describe them as being happy and fulfilled in spite of often very serious illness or disability. So these people have succeeded at biographical work. Others, of course, fail. They become isolated, suicidal, and large numbers of people, in fact, do kill themselves as a result of the loss of self and isolation and suffering that comes with chronic illness. So that's failure of biographical work. How would we measure the identity relevance of body failures? So some body failure that might matter a lot to me will matter very little to you, but physicians, nurses, other healthcare professionals don't have a very good way of measuring this, and they don't ask about it very much, and they don't talk about it enough. So if we took the trajectory model seriously, we would want measures of all of these things. So what are some hypotheses for research projects in this area? Regimens that cause identity-relevant body failures will not be integrated into self-regulation. SR is just my abbreviation for self-regulation. Regimens that repair identity-relevant body failures will be integrated into self-regulation. This is my way of not using the word adherence. Instead of saying adherence, I say these things will be integrated into self-regulation. I mean, people will be happy to do them because they work. Regimens that support or restore the alignment of the BBC chain will be integrated into self-regulation. And any regimen that destabilizes the BBC chain won't be integrated into self-regulation. So these are all variations on this main theme. If it helps keep the BBC chain together, people will do it. If it doesn't, they won't. So it means that a central task for healthcare professionals is to understand the current status of the connection between body, biography, and conceptions of self for all of their patients. And this will, of course, take time and a certain amount of relationship and intimacy, which isn't always available in the way we organize medical care now. So one observation we can make based on the trajectory model and what we've said is that the same side effect or intended effect will have a different effect depending on whether a regimen is incorporated into self-regulation, because the identity relevance of the side effect or intended effect will differ from person to person. That's a mouthful. So what am I really saying? A side effect which doesn't bother you at all might bother me tremendously. So a given side effect, let's say weight gain or dry mouth or having to pee frequently or insomnia or incontinence or impotence. So to take antidepressants often can cause impotence and they can cause weight gain. Some cause both, some cause one or the other. So for a person who's sexually active, impotence is a very identity-relevant body failure that they might not be willing to tolerate. Whereas they might be able to tolerate weight gain if it relieved their depression symptoms. For others, their weight problems might be central to their identity. And if they've lost weight, taking a medicine that makes them gain weight is unacceptable. Whereas they might be able to tolerate impotence or inability to achieve an orgasm if they're not sexually active. So whether a side effect is going to stop people from taking a medicine isn't a function of the side effect itself. It's a function of the connection between the side effect and its identity relevance. So if the side effect causes an identity relevant body failure, people are going to steer away from that medicine. If the side effect causes another body failure, which is unpleasant but doesn't disturb our identity or a critical performance, people can and will tolerate them. So we have to understand the identity relevance of these regimens and their effects. And if they have positive identity effects, we should predict people will take them. If they have negative identity effects, they won't take them. So I think this is, again, I'm sort of repeating myself in different ways, but the idea is so critical. If we want to understand the decisions that patients make, that chronically ill people make, decisions which on the surface seem perplexing. People come and they subject themselves to painful diagnostic procedures and they pay a lot of money and they take time off of work and we diagnose them and then we come up with a treatment plan and then they don't follow the treatment plan. So on the surface that seems irrational and that seems perplexing. But if we see it through their eyes and we realize that the treatment plan that we've given them interferes with a critical aspect of their identity or disrupts a critical aspect of their biography, then their decision not to take it is no longer irrational. So I want to claim that all of the behavior we see, which from a purely biomedical point of view seems irrational, is in fact, when seen through the patient's eyes, rational, sensible, and in fact normal. So for each illness and for each regimen, we need a kind of catalog of the body failures that the illness causes and a catalog of the body failures that the treatment causes. And then we need to talk those over with patients and negotiate a treatment plan that's not going to make that's not going to destroy the linkage between body, self, and biography. So from this point of view, picking a treatment plan is really about customizing the treatment to the BBC chain. The whole objective of treatment isn't lower blood pressure, lower blood sugar, lower weight. It isn't objective stated in terms of objectively measurable biomedical parameters. It's an objective stated in terms of restoring the stability and integrity of the connection between body, biography, and conceptions of self. So all treatments should be geared towards that goal. If the illness is causing a body failure, which is disrupting identity and biography, we want to see if we can help the person minimize that body failure by giving them medicine or some other regimen. So if pain is disrupting a critical identity relevant performance, we want to give people pain relievers or exercise or weight loss or ice or something that minimizes the pain. But often we have diseases without many symptoms, as early stages of diabetes or hypertension have no symptoms. We give people medicines that cause many more symptoms than the disease itself. We shouldn't be surprised then if those symptoms like, frequent urination or impotence for men or coughing or something like that disrupt identity more than the illness itself. We shouldn't be surprised when people don't follow these regimens. So we then need to plot a course of therapy that minimizes identity-relevant body failures. The goal is, at all costs, preserve the connection between body, identity, and biography. Preserve the integrity of the BBC chain as the primary therapeutic goal. Even this is a little bit too biomedical. So more generally, we want to focus on all disturbances in the BBC chain because, as I said in part one of the talk, sometimes the BBC chain can be disrupted by disruptions in biography, like unemployment or other sorts of life struggles. Sometimes the BBC chain can be disrupted by disruptions in identity. So we need to be attending to all disturbances in the BBC chain so we don't end up trying to treat what's really grief over a death or a divorce with medicine, where some other kind of treatment might be a much more logical way to restore the integrity of the BBC chain. So we still need an accurate model of human motivation, cognition, choice, and decision-making. I'm not going to have time to talk about this in great detail, but it is still critical. I've mostly focused on this ethnographic account of chronic illness. So poor rates of adherence, of sticking to regimens, are emblematic of a larger failure of the biomedical worldview. I think that the larger failure is that we conceptualize illness in biomedical terms, that is, in terms of deviations of these objectively measurable parameters from their normal values, or the presence of some objectively identifiable lesion on an imaging study or something like that. These biomedical definitions don't capture the experience of illness, but 50 years of ethnographic research with chronically ill people now does tell us about the experience of illness. And I think if we built a model of adherence or self-regulation on Corbin and Strauss and these others, we would have a much more success at understanding the decisions people make when they're sick. So these revolutionary developments in sociology, cognitive science, etc., have largely failed to penetrate into the biomedical education and practice. The trajectory model is not routinely taught to physicians. Nurses get it a little bit because Juliet Corbin was, in fact, a nurse. Pharmacy students got it when I was teaching pharmacy school, but most healthcare professionals don't get it. And so this perspective, which I've been trying to develop, most healthcare professionals, either only by their own intuition they get it or they don't get it at all, and they labor under this kind of mistaken conception of what it's like to be sick. So what are some caveats? I haven't talked at all about lots of other issues, about health literacy, which impedes people's ability to make good decisions about healthcare because they can't understand the materials we ask them to understand. Access. There's fundamental income inequality in our society, which limits people from even being able to get to clinics or hospitals and get the treatment that they need. This is a tremendously important issue, which I didn't discuss. Acute illness is still an issue. Millions and millions of people still have acute illnesses. Their suffering is just as real as the suffering of people who are chronically ill, but I focused only on chronic illness. And I've talked mostly about what I would call intentional non-adherence. That is, when people decide not to take the medicine, not to follow the self-diagnostic regimen, not to follow the diet, not to follow the exercise routine. I think intentional non-adherence is caused by these issues relating to identity and biography. But there still are people who really want to follow the regimen. They intend to, they want to, they desire to, but it's so complicated that because of health literacy or cognitive decline, they can't follow it, or because of overwhelming complexity, they're taking 8 medicines and they just can't figure it out. Or there are other reasons. And I haven't talked that much about unintentional noncompliance. And there, apps and pill boxes and all sorts of things, once-a-day regimens, can help people who want to comply have an easier time of it. So that's the end of my presentation. I appreciate you spending the time watching today. Thank you very much.